Good evening, Dr. Phil here. Today we will be discussing on nitrous oxide. Introduction. Nitrous oxide is an inhalational anesthetic agent isolated by Priestley in 1772. It is suggested as being a useful analgesic by Davy in 1799. It was first used for dental extraction by Wells in 1844 but was superseded by diethyl ether. It was reintroduced by Colton in 1863. Physicochemical properties. Nitrous oxide is a sweet-smelling, non-irritant, colorless gas. It is not flammable, but supports combustion of fuels when oxygen is absent. It has a low blood gas partition coefficient, 0.47 at 37 degrees Celsius. This results in rapid onset and equilibration. Oil gas partition coefficient is 1.4, molecular weight is 44, critical temperature 36.5 degrees Celsius, critical pressure is 72.6 bar, boiling point negative 88.5 degrees Celsius. It is 1.53 times denser than air. MAC is 105%. Nitrous oxide alone is insufficient to produce adequate depth of anesthesia, as a minimum FiO2 of 0.3 must be administered. Process of manufacturing nitrous oxide. It is manufactured by heating ammonium nitrate to 245 to 270 degrees Celsius. Risk of detonation is higher at higher temperatures. NH4NO3 becomes 2H2O plus 2N2O. Impurities produced when heating ammonium nitrate includes ammonia, nitric acid, nitrogen, nitric oxide, nitrogen dioxide, and water vapor. After cooling, ammonia and nitric acid are reconstituted to ammonium nitrate. This ammonium nitrate is reheated to produce nitrous oxide again. Impurities are removed via a series of scrubbers. Purified gases are compressed and dried using an aluminum dryer. Resultant gases are expanded in a liquefier. Nitrogen escapes as gas. Nitrous oxide is stored in cylinders after evaporation, compression and drying through another aluminum dryer. Higher oxides of nitrogen dissolve in water to form nitrous acid and nitric acid. If inhaled, this produces methemoglobinemia and pulmonary edema. Death has been reported during anesthesia due to inhalation of nitrous oxide contaminated with nitrous or nitric acids. Storage of nitrous oxide. It is stored in compressed form as a liquid. Nitrous oxide cylinders are painted blue in UK, pin index position 3 and 5. It is made of either carbon steel, chrome molybdenum steel, aluminum alloys, or stainless steel. At a pressure of 44 bar or 4400 kPa at 15 degrees Celsius or 54 bar at room temperature. Filling ratio is 0.75 in the UK or 0.67 in tropical countries. Cylinder phase is liquid and vapor at less than 36.5 degrees Celsius. Pipeline pressure of nitrous oxide is 4 bar. Large institutions use a pipeline supply of nitrous oxide from a large central bank of cylinders. Nitrous oxide cylinders must be kept in a vertical position during use so that the liquid phase remains at the bottom of the cylinder. Determining the amount of nitrous oxide remaining in nitrous oxide cylinders. As the cylinder contains liquid and vapor, the total quantity of nitrous oxide contained in a cylinder may be ascertained only by weighing the cylinder. The cylinder weights, full and empty, are stamped at the shoulder of the cylinder. The pressure reading on the cylinder can't be used to accurately estimate the amount of nitrous oxide remaining in the cylinder. As nitrous oxide is discharged from a cylinder, it vaporizes, requiring energy in the form of heat, which is the latent heat of vaporization, and ice may form on the lower part of the cylinder during continuous use. This process cools the cylinder, reducing the saturated vapor pressure and cylinder pressure. The pressure recovers when the cylinder is closed and it warms back to environmental temperature. The saturated vapor pressure will only decrease when all the liquid nitrous oxide is consumed and the tank is almost empty. Nitrous oxide is also supplied as gaseous Entonox. Q&A. What pressure exists in a half-full size D cylinder of nitrous oxide? What volume of nitrous oxide remains? In a nitrous oxide cylinder, nitrous oxide exists as a liquid form with a gas layer above. As the cylinder is opened, the liquid undergoes vaporization to maintain the gas layer as the nitrous oxide gas escapes from the cylinder. If the cylinder is being emptied slowly, the pressure reading will not change from 44 bar as when it is full until it is nearly empty as the liquid nitrous oxide layer maintains the gas layer. However, if it is being emptied quickly, the heat in the volume of liquid nitrous oxide is inadequate to supply the amount of latent heat of vaporization required to keep the gas layer at 44 bar, thus the pressure reading becomes unpredictable. In either case, a half-full size D cylinder of nitrous oxide contains 450 liters. What is the filling ratio and why is it important? The filling ratio is defined as the ratio of the weight of substance in the cylinder to the weight of water the cylinder could contain if fully filled. This is an issue for nitrous oxide and carbon dioxide because it is stored as a liquid in cylinders. There has to be a gas space at the top of the cylinder. Slight increases in ambient temperature can cause a dramatic increase in cylinder pressure and possible explosion if there is a very small gas space. The filling ratio is 0.75 in UK and 0.67 in tropical climates. Further details will be discussed in a video on gas cylinders. Mechanism of action of nitrous oxide. Anesthesia. Nitrous oxide strongly inhibits NMDA, which are mainly excitatory, activated currents. Neurotoxicity from NMDA antagonism is problematic only if N2O is used alone under hyperbaric conditions. GABA-A agonists may exert a protective effect to offset this neurotoxicity. Nitrous oxide has no effect on CNS GABA-A receptors, which are mainly inhibitory. Nitrous oxide stimulates some dopaminergic neurons. This may mediate release of endogenous opioid peptides. N2O analgesic effects are partly antagonized by naloxone. Analgesia. Nitrous oxide induces endogenous opioid peptide release. This occurs at the periaqueductal gray matter of the midbrain. It stimulates descending inhibitory noradrenergic pathways which modulate pain processing via noradrenaline release. Noradrenaline acts at the alpha-2 receptors in the dorsal horn of the spinal cord. Nitrous oxide also induces endogenous enkephalin release. This occurs at the supraspinal descending pain inhibition system. It results in inhibition of neurotransmission via substance P-dependent synapses. Single agent 66 to 70% nitrous oxide provides an analgesic effect similar to a whole blood concentration of remifentanil of 2 nanogram per ml. Metabolism. Metabolism of nitrous oxide is negligible by gut bacteria at 0.004%. Nitrous oxide is excreted unchanged from the lungs. Small amount diffuses through the skin to the atmosphere. Advantages of nitrous oxide. Central nervous system. It acts as a carrier gas for potent inhalational anesthetic agents. With a blood gas partition coefficient of 0.47, it has a rapid onset and equilibration and rapid recovery from anesthesia. Second gas effect. Rapid uptake of nitrous oxide from the alveoli increases the alveolar concentration of other agents and accelerates the induction of anesthesia. Nitrous oxide is a potent analgesic. Potency of morphine can be achieved transiently. There is decrease in chronic post-surgical pain. Survey data shows that Entonox provides more effective analgesia compared with petidine in mothers undergoing labor, 50% versus 35%. N2O is a weak anesthetic. MAC 50 is 105%, and it decreases MAC of other inhalational agents. Nitrous oxide confers neuroprotection by decreasing NMDA-induced glutamate excitatory toxicity. Nitrous oxide does not affect skeletal muscle tone. It does not appear to potentiate the action of non-depolarizing muscle relaxants. Nitrous oxide is non-irritating to the airways and only depresses respiration slightly. There is minimal effect on heart rate and blood pressure. Nitrous oxide can decrease myocardial contractility, especially if combined with volatile agents or opioids. Nitrous oxide does not affect hepatic or renal function. There is no effect on uterine tone. The Enigma Trial. Enigma Trial, which stands for Evaluation of Nitrous Oxide in the Gas Mixture for Anesthesia Trial, recruited 2,000 subjects undergoing major surgery for 2 or more hours. The authors concluded that major complications were greater in the group that received N2O than in the group receiving 80% oxygen in air, and concluded that the routine use of nitrous oxide should be questioned. It was not possible to determine whether the purported beneficial effects were caused by a high FiO2, the avoidance of nitrous oxide, or both, since no patients received FiO2 of 30%. Therefore, Enigma 2 trial was conducted. It is a randomized single-blinded study recruiting more than 7,000 subjects. The patients had medium to high cardiovascular risk. Primary outcome was composite of death and cardiovascular events, non-fatal MI, cardiac arrest, pulmonary embolism, and stroke within 30 days of surgery. Selected secondary outcomes include non-fatal MI, surgical site infection, severe post-op nausea, vomiting, etc. In the end, there were no differences in outcome between the two groups. There was a 15% incidence of post-op nausea, vomiting in the nitrous oxide group, which was eliminated by antiemetic administration. Disadvantages of nitrous oxide. Effects on air-filled spaces. Mechanism. Nitrous oxide in the blood equilibrates with closed air-containing spaces. Nitrous oxide is more soluble compared with nitrogen. The volume of nitrous oxide that diffuses into the cavity exceeds the volume of nitrogen diffusing out of that cavity. Thus, there is increase in volume of compliant air-filled spaces and increase in pressure in non-compliant air-filled spaces. Examples of non-compliant air-filled spaces includes the middle ear, nasal sinuses, the eye filled with gas such as after vitreoretinal surgery using SF6, and pneumocranium. Administration of 50% nitrous oxide increases the pressure by 0.5 atmosphere. Pressure change is related arithmetically to the alveolar partial pressure of nitrous oxide. There is increase in volume in compliant air-filled spaces such as pneumothorax, bullae, bowel, air embolus, and cuffs of tracheal tubes. Volume change is related arithmetically to the alveolar partial pressure of nitrous oxide. Percentage increase in volume of a compliant air-filled space equals the concentration in percent of nitrous oxide divided by 1 minus Fi N2O. At N2O of 50%, the final percentage volume increase is 100%. At N2O 75%, a pneumothorax will triple in size after 30 minutes of nitrous oxide administration. The volume of bowel can increase by 200% after 4 hours of 66% nitrous oxide. Emesis. Nitrous oxide induces emesis by sympathomimetic effects, opioid effects, and bowel distension. Concentration effect. It is a phenomenon where the rise in the alveolar partial pressure of nitrous oxide is disproportionately rapid when it is administered in high concentrations. Nitrous oxide is 20 times more soluble in blood compared to nitrogen. Outward diffusion of nitrous oxide from the alveolus to the blood is much faster than diffusion of nitrogen from blood to the alveolus. The higher the inspired concentration of nitrous oxide, the greater is the concentrating effect of nitrous oxide remaining in the alveolus. At increased inspired concentrations of nitrous oxide, the decrease in alveolar gas volume causes increases in PaCO2. Equilibration with pulmonary capillary blood results in an increase in PaCO2. The alveolus shrinks in volume and remaining nitrous oxide is concentrated within it. The resulting smaller volume of the alveoli results in alveolar ventilation increasing by drawing more gas into the alveoli from the airways in order to replenish the decrease in volume. The inspired concentration of nitrous oxide affects its rate of equilibration. The higher the inspired concentration, the faster is the rate of equilibration between the alveolar and inspired concentrations. This graph can be used to demonstrate the concentration effect of nitrous oxide. Fa is the fractional concentration of an agent in the alveolar gas. Fi is the fractional concentration in the inhaled gas over time. The y-axis is Fa over Fi, x-axis is minutes of administration. The order of the negative exponential curves is according to the blood gas partition coefficients. The more insoluble the agent, the steeper the curve, the faster the rate of onset of anesthesia, except for nitrous oxide and desflurane curves. Due to the concentration effect of nitrous oxide, the rise in the alveolar partial pressure of nitrous oxide is disproportionately rapid when it is administered at high concentration. All the lines eventually plateaus at Fa-Fi ratio of 1.0. As a result, the total volume of gas in the alveolus diminishes and the fractional concentrations of the remaining gases increase. This has two consequences. Higher concentrations of nitrous oxide results in increased Fa to Fi ratio for nitrous oxide, the concentration effect, and for a volatile agent administered with nitrous oxide, the second gas effect. The second gas effect is a phenomenon by which the speed of onset of inhalational anesthetic agents is increased when they are administered with nitrous oxide as a carrier gas. This is the result of the concentration effect. High concentrations of nitrous oxide results in increase in Fa to Fi ratio for nitrous oxide and for a volatile agent administered with nitrous oxide. If there is another gas present in the alveolus, then it will be concentrated by the decreased alveolar volume from the relatively rapid uptake of nitrous oxide into the blood. For example, if sevoflurane is administered with nitrous oxide, the reduction in gas volume in the alveoli caused by absorption of nitrous oxide increases the alveolar concentration of sevoflurane, thus augmenting the rate of equilibration with inspired gas. The second gas effect also causes small increases in PaO2 and PaCO2. Diffusion hypoxia. When nitrous oxide plus oxygen is switched to nitrogen plus oxygen at the end of anesthesia, hypoxemia may occur as the volume of nitrous oxide diffusing from the mixed venous blood to the alveoli is more than the volume of nitrogen taken up from the alveolus to the pulmonary capillary blood. This produces the opposite of the concentration effect. The gases in the alveolus is diluted by nitrous oxide. This leads to decrease in PaO2 by up to 4 to 11 mm mercury and decrease in PaCO2. Administration of oxygen after anesthesia has ended should avoid desaturation. Respiratory depression. Minute ventilation is maintained. There is increase in respiratory rate and decrease in tidal volume. There is decreased ventilatory response to decreased PaO2 and increased PaCO2. There is increased post-op respiratory complications if nitrous oxide is used due to decreased tracheal mucociliary flow and decreased neutrophil chemotaxis. Cardiovascular system. Nitrous oxide causes myocardial depression. There is negative inotropy, negative chronotropy, and decreased myocardial contractility. There is increased exacerbation of myocardial ischemia when myocardial oxygen demand exceeds supply. In normal individuals, nitrous oxide-induced myocardial depression is antagonized by indirect nitrous oxide-mediated sympathoadrenal stimulation. Therefore, healthy patients exhibit little change in the cardiovascular system during nitrous oxide anesthesia. However, in patients with heart disease, administration of nitrous oxide may cause reductions in cardiac output and arterial pressure in patients with pre-existing high levels of sympathoadrenal activity and poor myocardial contractility. Thus, nitrous oxide is avoided in some centers during anesthesia for cardiac surgery. Nitrous oxide can double the size of air embolisms as well, which can decrease cardiac output. There is increased pulmonary vascular resistance in the presence of pre-existing pulmonary hypertension. The mechanism is constriction of the pulmonary vascular smooth muscles. This results in increased right atrial pressure. Avoid use of nitrous oxide in patients with pulmonary hypertension. Central nervous system. Nitrous oxide causes increase in cerebral blood flow, increase in cerebral metabolism, and increased ICP. These changes are more marked in patients with abnormal cerebral autoregulation and may result in decreased cerebral perfusion. Bone marrow toxicity and neurotoxicity. Nitrous oxide inhibits methionine synthase, A biochemical lesion in the liver is detected after only 40 minutes of nitrous oxide administration. The mechanism of inhibition of methionine synthase. Vitamin B12 is a cofactor for methionine synthase. Nitrous oxide oxidizes the cobalt atom in the vitamin B12 or cyanocobalamin. CO2 plus becomes CO3 plus. This simple reaction inactivates methionine synthase. Function of methionine synthase. Methionine synthase catalyzes the transfer of a methyl group in a linked methyltransferase reaction. The methylation of homocysteine results in the formation of methionine. Demethylation of CH3 tetrahydrofolate results in formation of tetrahydrofolate. Outcome of methionine synthase inhibition. Decreased methionine production results in decreased SAM and decreased S-adenosyl methionine incorporation into the myelin causes subacute combined systems degeneration of the spinal cord. Acute presentation is dorsal column function impairment similar to chronic vitamin B12 deficiency, and it occurs after 48 hours of 20% nitrous oxide administration. There is decreased tetrahydrofolate production. Tetrahydrofolate is an important substrate involved in nucleotide and DNA synthesis. Megaloblastic anemia occurs in folate and B12 deficiency. Exposure to nitrous oxide for 6 hours or longer may result in megaloblastic anemia. Prolonged exposure may result in agranulocytosis and bone marrow aplasia. Management of nitrous oxide-induced marrow and neurotoxicity. Stop nitrous oxide administration and administer methionine and folinic acid. These provide some substrates to allow biosynthesis to continue below the level of the enzyme block. Reproductive system. Nitrous oxide alpha-1 adrenoceptor agonism is very weakly associated with left-right body axis development such as situs inversus. No direct evidence exists for nitrous oxide-induced fetal abnormalities or spontaneous abortion. N2O may reduce fertility in female healthcare workers chronically exposed to nitrous oxide. Areas that do not use anesthetic gas scavenging systems or have inadequate ventilation, such as recovery, dental suites, radiology, and labor rooms, are at risk of exceeding these exposure limits. The safe exposure limit in the UK is 100 ppm, and in the USA it's 25 ppm. Nitrous oxide is considered as being safe to use in pregnancy. There is one definite case report of nitrous oxide-induced malignant hyperpyrexia, and thus nitrous oxide is considered to be a weak trigger. Hyperbaric nitrous oxide. Nitrous oxide has excitatory effects when administered under hyperbaric conditions. There is increased respiratory rate by more than 3 times, diaphoresis, increased MAP from cardiovascular alpha-adrenergic stimulation, CNS-mediated muscle rigidity, catatonic jerking, and anesthetic effects. Greenhouse effect. N2O is a greenhouse gas 300 times as potent as carbon dioxide in its potential to trap atmospheric heat. Anesthesia contributes to about 1% of the global total output. Other sources of N2O includes bacteria production and nitrate fertilizer use. These are my references. Thank you.